Now, you were looking at something called mismatch repair deficiency. Sounds very interesting because it was being described as a way of actually signaling which cells are cancer and then how to go and get them. What were you actually doing there?
So mismatch repair deficiency just means that these tumors are deficient in proteins that are involved in mismatch repair, so DNA repair. And so because they're deficient in these proteins, their tumors generate hundreds to thousands of mutations that can then be recognized by the immune system, almost like a foreign protein. And so it is a kind of a red flag that says to the immune system, this is something different that can be targeted.
So what is it about the immune system that notices these different things? It's because they are foreign, basically.
Well, they look a little bit more foreign than what we call wild type, which is the normal. So the T cells are in the body that can recognize it, but they go into the tumor and then they're turned off. And so giving it an immune therapy, such as a PD-1 blocker, can take the brakes off of those T cells and then can cause an immune reaction to the tumor.
Can you tell me what you did in your study?
So what we did is we tested the drug pembrolizumab, which is an anti-PD-1, and we tested it in 3 cohorts of patients. The first 2 cohorts of patients were colorectal cancer patients, and in the first cohort, they were colorectal cancer patients with mismatch repair deficiency. In the second cohort, they were colon cancer patients with mismatch repair proficient tumors. And in the third cohort, we really were asking the question about mismatch repair deficiency, and so it included any tumor type that had mismatch repair deficiency. And so what we did is we looked at their responses, and we saw 0 responses in the colon cancer patients with mismatch repair proficiency, but 62% response rate in the colon cancer that was mismatch repair deficient, and 60% response rate in the non-colorectal patients with mismatch repair deficiency. So it really was limited to the mismatch repair deficient cohorts.
Now, you almost never hear of such a sharp difference between a tumor positive for something and a tumor negative for something. What did you make of these?
Because I really think we were testing that hypothesis that the high mutational load is what is predicting the response to this therapy. And we know that the deficient tumors are very high in mutational burden compared to the proficient tumors.
And you used a PD-1 targeting agent.
We did.
What happened then? I mean, that was it basically.
Yeah, so the patients in the deficient cohort responded. A good number of them responded, and for a very long time. So many of the responses are lasting over a year.
What's the clinical significance of that?
This is a patient population that's had mostly 2 or more prior therapies. Their survival is measured in months, maybe somewhere between 4 and 6 months. And we've been following patients with a median of 7 to 8 month follow-up for the entire group. And so this is really making a difference in survival of these patients because we're able to stop what's happening and regress it. These are all treatment refractory progressive patients, meaning their cancers were growing before coming into the study.
What could this mean in the real world? You had a very refined experiment there, but could clinicians perhaps think about using these sorts of processes?
Well, so I envision a day where they will. Of course, this is a very small study, so we need to study in more patients, and we are expanding those cohorts in our study, and Merck is also planning subsequent industry-sponsored studies in these various diseases. So I think we need more data, but the testing is clinically available, commercially available as part of standard of care. So it's not something where a test necessarily needs to be developed.
Is it something then that should be routinely carried out, do you think, right now?
I think it's a bit early. Again, it's a very small study. I think the data is very promising, and again, I think we just need to study more patients with the agents before doing it routinely.
So what's the clinical bottom line message to take home?
I think the bottom line is that, I think this, if we can prove this with a larger number of patients, that eventually it will be part of the armamentarium for this subset of patients across disease types based on a genetic marker as opposed to based on a histology.